Hello, I'm Dr. Kenneth Taylor. I'm the director of the Hypertrophic Cardiomyopathy Center at Piedmont. I'm here today to talk to you about hypertrophic cardiomyopathy, contemporary approach to diagnosis and management. I have the following financial disclosures. I am on the Speakers Bureau for Bristol Myers Squibb, and all relevant financial relationships have been mitigated by Piedmont Healthcare. This educational opportunity does have CME credit as noted. So we're going to start with a pretest today with a few questions, and then we'll address these questions at the end of the talk. What percentage of patients with hypertrophic cardiomyopathy will have a left ventricular outflow tract obstruction at rest or with provocation? 37%, 70%, 50%, or 30%. Question number 2, patients with hypertrophic cardiomyopathy and atrial fibrillation should be anticoagulated based on CHA2DS2-VASc scoring system, the presence of left ventricular outflow tract obstruction, the degree of hypertrophy, or regardless of risk for stroke. And finally, what is the most common genetic abnormality found in patients with hypertrophic cardiomyopathy? TTN gene, TPM1 gene, myosin-binding protein C3 gene, or the ACTC1 gene? Okay, here's the outline for our talk today. We're going to go through background on hypertrophic cardiomyopathy, including history, prevalence, definitions, clinical presentations, pathophysiology. We will talk a little bit about the contemporary diagnosis and therapeutics, including family screening and treatment. Discuss risks for sudden cardiac death, atrial fibrillation, heart failure, exercise and athletic recommendations, and then talk about the Hypertrophic Cardiomyopathy Center here at Piedmont. So hypertrophic cardiomyopathy is the single most common reason why young athletes die. These were two very famous basketball players who died on national television and ended up being diagnosed with hypertrophic cardiomyopathy. So this diagnosis is not uncommonly in the public realm. As I mentioned, it is the most common reason why young athletes die, and so it becomes a very important diagnosis in young athletes. It was first described in the late 50s out of England as an asymmetric hypertrophy of the heart in young adults. By 2011, we had our first set of guidelines referenced here, and then in 2020, we finally redid those guidelines and have the most updated version from the AHA-ACC publication. Hypertrophic cardiomyopathy is a common genetic cardiovascular disorder. The phenotype is present in about 0.2% of the general population, but it probably is more common than we see phenotypically, because there are patients who have the gene or have a genetic predisposition without having representation or what we call phenotypic expression. Those so-called genotypic positive, phenotypic negative patients. Hypertrophic cardiomyopathy is defined as a disease state where there is thickening of the heart or left ventricular hypertrophy in excess of that which would be expected, typically greater than 15 millimeters anywhere in the ventricle, in the absence of anything else that can cause thickening. There have been a lot of terms used for this diagnosis over the years, and in 1979, hypertrophic cardiomyopathy was coined as the best overreaching term for this. There are a lot of other terms, including IHSS, HOCM, and so forth, but HCM is kind of the term that we typically use. The pathology of hypertrophic cardiomyopathy is that of myocardial thickening, and it can happen anywhere in the ventricle. And there is, of course, a differential diagnosis. Patients with chronic renal failure can have ventricles that look a lot like hypertrophs. Patients who are athletic or athlete's heart can look like hypertrophic cardiomyopathy, and then a number of infiltrative diseases can mimic this disease. The presentation can be variable. A lot of patients will present with no symptoms at all, either with an abnormal EKG, a murmur on exam, as part of a screening profile for athletes, or being evaluated because of a family history. Sometimes patients can present with syncope, shortness of breath or chest pain, atrial fibrillation, or an incidental finding because of some other cause. There are several major pathophysiologic expressions of this disease, and we'll go through each of these. Left ventricular outflow tract obstruction, diastolic dysfunction, autonomic dysfunction, myocardial ischemia, and mitral regurgitation. The underlying pathophysiology of hypertrophic cardiomyopathy is that of sarcomeric dysfunction. Essentially that the myofilaments of the heart muscle are hypersensitive to calcium, and there's increased myosin ATP ACE activity. And so there is increasing myosin active cross-bridging. The analogy I like to make is that of a boat with oars in the water. And patients with hypertrophic cardiomyopathy have more oars in the water pulling the actin and myosin together. And that results in a hypercontractile state of the myocardium. It also uses up more ATP, or uses up more energy, and can lead to a number of abnormal pathophysiologic problems. Dynamic obstruction, one of the pathophysiologic findings in HCM, is present in some percentage of patients. And in the dynamic obstructive form of this disease, there is asymmetric septal hypertrophy, or thickening of the septum, just under the outflow tract under the aortic valve. The septum then moves into the outflow tract and creates an obstructive narrowing of the outflow tract. And it's a combination actually of both the septum coming into the outflow tract and a so-called Venturi effect, where the anterior leaflet of the mitral valve is kind of sucked into the outflow tract, and that combination results in a narrowing and an obstruction to blood flow getting out of the heart. We see this on echo as something called systolic anterior motion of the mitral valve. So here's a classic example where you can see asymmetric septal hypertrophy here. Here's the mitral valve with the anterior leaflet, and during systole, the anterior leaflet is sucked into the outflow tract and actually touches with so-called mitral septal contact, leading to obstruction of blood flow trying to get out the outflow tract. That results in an increasing gradient across the outflow tract, so the pressure in the ventricle is higher than the pressure outside of the ventricle, or more importantly, in the outflow tract. We can see this by Doppler with an increased velocity as measured by either pulse wave or continuous wave Doppler. There are things that can make outflow tract gradients worse. They tend to be dynamic and relate to both the filling, the preload, and the afterload, as well as the inotropia of the ventricle. So at rest, you may have not much of a gradient, but with Valsalva, it may go up, and with particular vasodilators, it can go up even higher. It turns out that the presence of obstruction is a bad thing and can lead to worsening outcomes. So those patients who are non-obstructive have better outcomes than patients who are obstructive in terms of their risk for developing congestive heart failure and death. Autonomic dysfunction is present in about a quarter of patients with hypertrophic cardiomyopathy. It's typically seen as a failure to increase systolic blood pressure with activity. It can be related to dynamic obstruction, but it doesn't have to be. And it is also associated with a poorer prognosis. Diastolic dysfunction is common in patients with hypertrophic cardiomyopathy, whether they're obstructive or not. This may be from diffuse myocardial ischemia, the thickening of the myocardium, and it's often a contributor to exertional symptoms. We can evaluate diastolic dysfunction by echo with mitral inflow and tissue Doppler evaluation. Myocardial ischemia and even myocardial infarction can be seen unrelated to the presence of coronary artery disease, classically seen as a supply-demand mismatch with increased oxygen demands created by the hypertrophy of the ventricle and adverse loading conditions. There is oftentimes seen microvascular dysfunction, which can additionally lead to ischemia. Mitral regurgitation is common in patients, particularly with left ventricular outflow tract obstruction. It typically is a secondary phenomenon. As I mentioned, the anterior leaflet of the mitral valve can be sucked into the outflow tract, and this opens the mitral valve and leads to mitral regurgitation. So there's typically a correlation between the degree of mitral regurgitation and the degree of outflow tract obstruction. Here is classic mitral regurgitation related to systolic anterior motion of the mitral valve. You see the outflow tract here. Here's the anterior leaflet of the mitral valve. And the jet of mitral regurgitation is typically a more posteriorly directed jet related to the pulling of the anterior leaflet into the outflow tract and a jet going in the opposite direction. Here's a transesophageal echo showing the same thing. Here's the anterior leaflet of the mitral valve, and there's the posteriorly directed mitral regurgitant jet. We can again see this by Doppler echo, and there's typically a different morphology of the mitral regurgitant jet to the left ventricular outflow tract jet. Sometimes these can be very difficult to distinguish, and especially if you use continuous wave Doppler, you can oftentimes get overlap. And it turns out the mitral regurgitant jet is a much higher velocity than typically the outflow tract, and it can lead to abnormal measurements and erroneous measurements of the left ventricular outflow tract gradient. So one has to be very careful when doing Doppler echocardiography to help distinguish the mitral regurgitant jet from the left ventricular outflow tract velocity. Heart failure is something that we do see in patients with hypertrophic cardiomyopathy, both with preserved and reduced left ventricular function. In patients with hypertrophic cardiomyopathy, their normal ejection fraction is hyperdynamic. So we actually consider left ventricular systolic dysfunction to be an ejection fraction of under 50% in patients with HCM as opposed to under 40% in the normal population. On physical exam, we will oftentimes hear a murmur, especially in the obstructive form, although non-obstructive hypertrophic disease may not have a murmur. S4 gallops, rapid upstrokes, and a second murmur of mitral regurgitation is common. EKGs in patients with hypertrophic cardiomyopathy may be normal or may be markedly abnormal, oftentimes with left ventricular hypertrophy, deep T-wave inversions, dagger-like septal Q waves are typically seen. There are multiple different patterns of hypertrophy, and we use echo as the first line of imaging in hypertrophic cardiomyopathy. The hypertrophy can be concentric, eccentric, can include the outflow tract, the apex, or any other parts of the myocardium. The more typical patterns, which we'll see in a moment, include reverse curved septum, sigmoid septum, neutral septum, apical, and mid-ventricular. So here are some of those examples: the reverse curved septum, the sigmoid septum, or classic proximal septal hypertrophy, kind of a neutral septum, apical, and mid-cavitary. Here is a reverse curve septum, which typically is less obstructive or non-obstructive. You can see a little chordal septal contact, but the actual outflow tract here seems to be free of narrowing or obstruction. This is a massive septal hypertrophy, so the whole apex and half of the myocardium here is massively hypertrophied. These are typically non-obstructive forms of hypertrophic cardiomyopathy. And then here's a mid-cavitary where the thickening is in the mid-cavitary, oftentimes leading to thinning or even aneurysmal dilatation of the apex, with even the potential for infarction and aneurysms. If you look at left ventricular outflow tract gradients, one typically finds that about a third of patients will be non-obstructive. A third of patients will have no obstruction at rest, but with exercise will develop an obstruction. So about a third are non-obstructive, a third are non-obstructive at rest but develop obstruction with exercise, and about a third have obstruction at rest. So overall, 70% of patients will either have rest obstruction or rest and exercise obstruction. So it becomes important to try to distinguish, particularly in those patients who do not appear to have a resting gradient, that they don't develop one with exercise. And here's some data from Marty Marin showing that in a group of patients who did not have resting gradients with exercise, many of them developed significant outflow tract gradients. And to that end, in the guidelines, stress testing is recommended for patients who have no resting gradients but potentially symptomatic patients who don't have a resting gradient, in an effort to try to provoke an exercise gradient utilizing stress echocardiography. We look for the provocation of gradients with a few different things, mostly Valsalva maneuver and exercise echo, which is really the key test both for assessing symptoms and for exercise gradient. We typically do not use post-PVC response, isoproterenol infusion, amyl nitrate, and definitely not dobutamine infusions, which are not physiologic. MRI is commonly used in patients with hypertrophic cardiomyopathy to clarify the diagnosis, particularly if the echo is inconclusive, to evaluate for alternative diagnoses such as infiltrative cardiomyopathies, and to give us more information about the morphology, the LV thickness, mitral valve abnormalities, and particularly to assess for late gadolinium enhancement as it relates to assessment of risk for sudden cardiac death in this patient population. Here are some MRIs showing some of the morphologies we just looked at: mid-cavitary, massive septal hypertrophy, apical lateral, apical, and classic proximal septal hypertrophy. Monitoring is an important part of the management of patients with hypertrophic cardiomyopathy because of the potential risk for arrhythmias and the risk for sudden cardiac death. The guidelines recommend monitoring once every year or two as part of the evaluation for sudden cardiac death, and EKGs in the screening of patients and patients' families for this disease. Family screening is very important. As I mentioned, this is a genetic disease, and there are two pathways that we typically employ for screening first-degree family members, either genetic testing or clinical testing. The genetic testing pathway, we test the proband or the patient with the disease, and if they are positive for a gene, we then test all of their first-degree relatives, and then only those relatives who have the gene need to be followed with clinical testing. Unfortunately, about 2/3 of patients who have hypertrophic cardiomyopathy will not have an identifiable gene, and so we need to use clinical testing, which means echoes and ECGs every 3 to 5 years in adults that are family members of patients with hypertrophic cardiomyopathy. There are a number of genes that have been identified, and there are likely more that we don't know about. A lot of times when you do genetic testing, you get a variant of unknown significance, but there are 4 very common genes, of which 2 of them, the MYH7 and the myosin-binding protein C3 gene, are kind of the most common genetic abnormalities we see in this disease. There are many variants of unknown significance, and over time, some of those may turn out to be pathologic variants as we learn more. Pharmacologic management centers primarily in the obstructive form of hypertrophic cardiomyopathy with using medications to decrease the force of contraction, and that typically is beta blockers as first-line choice. And depending on whether patients either tolerate or respond to beta blockers, either substitution or the addition of non-hydropyridine calcium channel blockers like verapamil or diltiazem. Additionally, we will sometimes add disopyramide. This is from the guidelines, which came out prior to the approval of our new class of medications, the cardiac myosin inhibitors, which I will discuss now. Cardiac myosin inhibitors is a new class of medications that has now been approved for the use in hypertrophic cardiomyopathy. These were approved after the most recent guidelines, so they are not in the guidelines. We'll talk a little bit about the pathophysiology, the clinical trials, the FDA approval, and limitations and concerns with these medications. So as I mentioned earlier, the hypertrophic cardiomyopathy is a disease of the sarcomere, and it's related to actin and myosin cross-bridging. As I mentioned, patients with this disease have a hypersensitivity of myofilaments to calcium and an increase in myosin ATPase activity. So there are more myosin-active heads interacting together. These new class of medicines are designed to inhibit this cross-linking. As I mentioned, the sarcomeric hyperactivity leads to hypercontractility, hypertrophic changes, increasing energy requirements, outflow tract obstruction, and symptoms. There are now 2 cardiac myosin inhibitors that have been investigated, one of which is currently FDA approved, mavacamten, the other is aficamten. And these are both selective cardiac myosin ATPase inhibitors that are reversible. And essentially what they do is they inhibit the binding of actin to myosin cross bridges, and thereby reduce the likelihood of those cross bridges forming and reduce the myocardial hypercontractility. Going back to the oar analogy, it's like having half of the oarsmen pull their oars out of the water, and so there's less myocardial hypercontractility. Mavacamten was the first to be FDA approved in April of 2022. It's a targeted reversible inhibitor of cardiac myosin, and it works by targeting the myosin ATP in the sarcomere, decreasing the number of myosin-actin cross bridges. There have been a few clinical trials. The primary large trial was the Explorer trial, and then the secondary one was Valor. We'll look at these. The Explorer trial was a phase 3 multicenter trial looking at patients with elevated gradients and class 2 to 3 symptoms, with a primary endpoint being a composite functional endpoint, both in symptoms and function, as well as secondary endpoints of maximum oxygen consumption and left ventricular outflow tract gradients, as well as Kansas City Cardiomyopathy Questionnaire. This was a markedly positive study showing patients significantly improved both in terms of their symptoms, their VO2 max, and their left ventricular outflow tract gradients. A small percentage of these patients had a reduction in their heart function requiring stopping the medication, 3%. All were reversible, so when the medication was stopped, the heart function improved again. The Valor trial was another trial where they took patients who were being evaluated for septal reduction therapy and then randomized them to mavacamten versus placebo, again looking at composite endpoints. And what it demonstrated was, again, a remarkable reduction in symptoms and improvement in left ventricular outflow tract gradients. And in fact, it shifted a number of patients, a large percentage of patients, no longer were eligible for septal reduction therapy after being treated with mavacamten. So it took a group of sicker patients who were heading towards septal reduction therapy and demonstrated that with this treatment they could no longer necessarily need septal reduction therapy. There were secondary reductions in left ventricular outflow tract gradient at rest and with Valsalva, very mild reduction in left ventricular function, improvement in KCCQ scores, and improvement in biomarkers including NT-proBNP and troponin. Aficamten has also been studied in a couple of trials, the Redwood trial, which was completed, and the Sequoia, which just came out, which was also a phase 3 multi-center randomized trial. This myosin inhibitor has also demonstrated improvement in symptoms and an improvement in VO2 max in the Sequoia trial, as well as reduction in gradients and improvement in biomarkers, as demonstrated here in the Redwood trial. There are a number of ongoing extension trials for obstructive hypertrophic cardiomyopathy with both of these drugs. The MAPLE trial has just started enrolling, which is the first comparison trial of aficamten to metoprolol. So we've never had a head-to-head trial looking at beta blockers versus a myosin inhibitor. So MAPLE has just started. One of the concerns with the mavacamten is this issue of both reduction in left ventricular function and a number of drug-drug interactions. So the FDA recommended a program called the REMS program. So any patients put on this drug have to get enrolled in the REMS program, where their heart function by echo is monitored very closely every month for the first 3 months and then every 3 months thereafter. And there's also a very specialty pharmacy that looks very closely for drug-drug interactions. As I mentioned, one has to be careful watching for left ventricular dysfunction, drug-drug interactions. It's contraindicated in pregnant patients, and patients need to be followed very closely. Here are a long list of some of the drug-drug interactions, so a specialty pharmacy is clearly necessary. Cardiac myosin inhibitors are being looked at in non-obstructive hypertrophic cardiomyopathy. There are a large number of patients with non-obstructive disease, and these patients tend to have poor outcomes, and there's not been much in the way of treatment for them. So there are a couple of studies looking at this. The MAVERICK trial looked at a group of non-obstructive patients with significant symptoms and elevated NT-proBNP, and demonstrated a reduction in NT-proBNP and troponins. There are other studies ongoing, including Acacia, Odyssey, and Embark. So we will learn more over the next few years about the effectiveness of this therapy in non-obstructive hypertrophic cardiomyopathy. All right, let's switch now to invasive treatments for symptomatic patients with obstructive hypertrophic cardiomyopathy. So patients who fail medical therapy, either beta blockers, calcium channel blockers, or myosin inhibitors, may be candidates for more definitive therapy with septal myectomy or alcohol septal ablation. And essentially what these two techniques do, either through surgery or through the interventional lab, is to reduce the myocardium at the outflow tract and thus reduce gradients and improve outcomes. The indications for septal reduction therapy are persistent symptoms, particularly New York Heart Association class 3 or 4 symptoms on optimal therapy and with elevated left ventricular outflow tract gradients. And it turns out if you look at surgical myectomy, it significantly improves long-term outcomes in patients with obstructive HCM. So if you compare a group of patients who have had myectomies to patients with obstruction who are managed medically, there's a significant survival improvement. When you compare outcomes for myectomy versus alcohol septal ablation, although these studies were not that large, they generally show similar outcomes. However, patients who have alcohol septal ablation may need more therapy in the future. So they may need additional septal reductive therapy. And they may be at higher risk for arrhythmias, AV block, repeat procedures, and the lack of the ability to address other common abnormalities such as mitral valve abnormalities, Mays procedures, makes alcohol septal ablation not quite as ideal as a definitive therapy for this disease. Particularly in patients who have mitral valve abnormalities, so abnormalities of attachment of the mitral valve, long leaflets, massive hypertrophy, surgical approach tends to be a better approach. And in fact, if you look at the guidelines, in patients with hypertrophic obstructive cardiomyopathy who continue to be symptomatic, a recommendation to refer to a center with, that does high volume is one of the first recommendations. And then particularly in patients who have other anatomic needs, surgery is recommended. And alcohol septal ablation is typically reserved for those patients who are not good surgical candidates. Mitral valve abnormalities were not really part of the original pathological and clinical description of HCM back in the 50s, but over the last 70 years, we've learned a lot about the mitral valve and how it contributes to and participates in this disease. And so mitral valve abnormalities or malformations have been identified at all levels, including elongated leaflets, abnormal attachments to the anterior mitral valve. In patients with hypertrophic cardiomyopathy, they are at risk for sudden cardiac death. I mentioned at the beginning that it is the most common reason why young athletes die. And so assessment of a patient's risk for sudden cardiac death continues to be important. And we have a number of risk factors that we know about that increase a patient's risk for sudden cardiac death. And there are pathways, both in the guidelines and within multiple centers, including our own, looking at these risk factors and using them to help decide on indications for defibrillator therapy. We know people at highest risk are those who have had a cardiac arrest and have survived, have sustained ventricular tachycardia, have passed out, have massive hypertrophy, or have apical aneurysms. It turns out there are other markers for risk, and we can use late gadolinium enhancement by MRI as an additional risk factor. So we know that patients who have non-sustained ventricular tachycardia and late gadolinium enhancement are at a higher risk. And it turns out that late gadolinium enhancement can be quantitated, and the higher degree of LGE, the higher the risk. So we can look at people who have arrhythmias and over 15% LGE as being in a higher risk category and reclassify them as someone who might need to be evaluated for an ICD. Those in the intermediate range, in the 10 to 15% LGE range, we may be able to monitor closely or use things like ILRs. And then those with low LGE may be at a lower risk. Atrial fibrillation is common in patients with hypertrophic cardiomyopathy, and it turns out that these patients are at an increased risk of stroke. And that increased risk of stroke is independent of the CHA2DS2-VASc scoring system. So one of the important take-homes is that we do not use CHA2DS2-VASc scoring system to identify risk for stroke. So patients with HCM who have atrial fibrillation should be anticoagulated independent of CHA2DS2-VASc scoring system. This is the most common arrhythmia seen in HCM, AFib and aflutter. Antiarrhythmic drugs have been utilized. A lot of times these patients do not tolerate atrial fibrillation very well and do carry a higher risk of stroke, so we anticoagulate them and we aggressively try to maintain sinus rhythm in this population of patients. The guidelines list a number of different medications as class 1 indications for utilization for symptomatic ventricular arrhythmias as well. Heart failure can develop in patients with hypertrophic cardiomyopathy. As I mentioned, that we use a different threshold for ejection fraction to consider systolic dysfunction, an ejection fraction of under 50%. So when we see an EF of under 50%, we start talking about and instituting traditional guideline-directed medical therapy for systolic heart failure. Exercise has been an interesting topic in this disease. For the longest time, patients were kept from doing any exercise. And we look at exercise in both static and dynamic components of their exercise. And here are a bunch of different sports with different degrees of dynamic or static components. And for the longest time, patients with HCM were relegated to this box here. So they could bowl, do cricket, curl, play golf, riflery, or do yoga. Well, when that happens, people tend to pick up weight, and it's not a very healthy lifestyle. So over the years, we've learned a little bit more about what we can do in our patients with hypertrophic cardiomyopathy. And we're shifting our ideas to allow for more exercise, including moderate intensity and even high intensity, and high intensity in athletes, with a fair amount of careful attention to detail and shared decision making. And so we've shifted our idea to allow patients more recreational exercise and maybe even get into highly intense competition, again, with a very careful shared decision making between the patients, the centers, and the doctors. What we've learned is that the beneficial effects of exercise in general health can be extended to patients with hypertrophic cardiomyopathy. So this requires an extensive conversation with patient and doctors. And we've shifted in the guidelines to allow patients a class 1 indication for mild to moderate intense recreational exercise, and even for athletes, a consideration of allowing some degree of athletic competition. We still do not recommend placing ICDs for the sole purpose of participation in competitive athletics. There is a big focus in our field and in the guidelines on this concept of shared decision making, that a lot of the decisions about testing and treatment and athletics and so forth really need to be engaged as in a robust patient-physician or patient-practitioner conversation. Additionally, multidisciplinary hypertrophic centers have been recommended in both sets of guidelines, particularly in patients who have challenging treatment decisions where alternatives exist and with strengths of recommendations may not be as strong, that comprehensive centers that take care of a lot of patients with this disease can be very helpful. And in fact, is a class 1 indication for patients in whom septal reduction therapy is indicated. So let's talk a little bit about the Hypertrophic Cardiomyopathy Center here at Piedmont. We have built a multidisciplinary team, including cardiologists, CT surgeons, interventional cardiologists, imagers, electrophysiology, and sports cardiologists, to create a comprehensive multidisciplinary team to help manage patients with HCM. We offer guideline-directed therapy and state-of-the-art diagnosis and treatment for this disease. Our goal ultimately is to obtain certification by the HCMA and become a center for research in HCM and be a center in the Southeast for management of this patient population. Here is the timeline of our process. We started in 2015 with our first presentation and have worked on pathways, which then after COVID we kind of rebuilt, and we're currently in the next phase of outreach and education to patients and practitioners. I'll briefly show you some of our protocols, which are available on our Piedmont's website, including diagnosis, treatment, imaging, exercise, new pathway on cardiac myosin inhibitors. I don't need to go through each of the little boxes, but this is the diagnostic pathway, which helps practitioners walk through how best to make a diagnosis of HCM, including both phenotypically negative and phenotypically positive patients. Treatment algorithms, including obstructive disease, including treatment with traditional beta blockers as well as cardiac myosin inhibitors, and each of these boxes leads to the next set of pathways. This is a management protocol for non-obstructive symptomatic that leads to including both preserved and reduced left ventricular function and heart failure. And then management of atrial fibrillation. Our electrophysiologist helped us put together this pathway, as well as 2 different pathways for risk assessment for sudden cardiac death. And then lastly, invasive therapies for patients who need to be considered for septal reduction therapy. We have imaging pathways for transthoracic echocardiography, stress echocardiography, CVMRI, and then an extensive set of guidelines and recommendations for exercise from our sports cardiology division. Lastly, the new kid on the block are cardiac myosin inhibitors. We have inclusion and exclusion criteria, and then a series of practitioners who are certified and work with the REMS program to be able to administer these medications and follow them safely and appropriately. This is our team of HCM cardiologists in the different regions: Atlanta, Fayetteville, Athens, Blairsville, and Augusta. We've also worked with AEP in all of these areas, but Dr. Hussein has helped us with a lot of the protocols. Our CT surgeon, Dr. Thorani, and interventional cardiologist, Pradeep Yadav, have both been also important team members. So let's finally finish this with the tests that we took at the beginning. So what percentage of patients with HCM will have left ventricular outflow tract obstruction at rest or with provocation? As we mentioned, it's about 70%. Patients with hypertrophic cardiomyopathy and atrial fibrillation should be anticoagulated based on CHA2DS2-VASc scoring system, presence of left ventricular outflow tract obstruction, degree of hypertrophy, or regardless of risk. And as I mentioned, it's regardless of risk. So we do not use the CHA2DS2-VASc scoring system to decide on anticoagulation. And finally, the most common genetic abnormality found in patients with HCM is the myosin-binding protein C3 gene. Thank you very much for your attention today. If we can be of any help answering your questions or helping you with any of your patients, please feel free to reach out to any of us on the team.